Test, test. Hello, everyone. Welcome to our first grand rounds. Yay! All right, we are going to be starting with Dr. Paige Coughlin, who began her studies at WashU in St. Louis, earning a degree in bio while competing in varsity swimming and club water polo. She then went on to earn her MD at Drexel University College of Medicine in 2023. Then she returned here to WashU. Now in her PGY3 year, she is an aspiring cardiologist, blending clinical excellence with research into her future in cardiovascular medicine. Please welcome Paige Coughlin.
Can you guys hear me okay? Okay. Thank you, Emma, for the introduction. Thank you all for being here. My name is Paige. I'm a PGY3. I'm interested in cardiology, and my talk today is going to be on AI for MI, a retrospective analysis of a phone-enabled application for myocardial infarction. So it wouldn't be a cardiology talk without me giving you an EKG. So I'd like you to contextualize this EKG as an intern on night flow, and you're going to 9200 or 10200, and the patient has chest pain. And the nurse hands you this, and they ask, what do you want to do? Do you want to call cardiology? Do you need some help? Do you want to activate the MI pager? You're sure of what's going on? You want to tell the patient to go to bed? What would you like to do? And so we're going to come back to this. But I'm hopeful that this talk today is helpful for everybody, because at the end of the day, we're all going to see patients with chest pain. And I think we all would feel a little bit better if when we saw a patient with chest pain, we had something in our back pocket to make us feel a little bit more reassured that what we're looking at is, an ACS event, an acute coronary event, something that made you feel reassured in calling cardiology or not, right? And in order to kind of build that framework, we need to understand what our limitations are of the things we have access to currently. So those include our limitations to human ECG interpretation, our understanding of computer algorithms. We're going to then explore how AI could help in this space and what it could change clinically. And so then our first question, of course, is how accurate are humans, right? Before there were computers, there were humans reading ECGs. And also, we are the ones who activate the cath lab, right? So how accurate are we? So this first study here, this is a study of 124 physicians of different specialties. They had them read 5,000 ECGs. And among the physicians, there were multiple groups, as I said, a lot of emergency physicians and cardiologists included. And they found that true STEMI accuracy was about 65%. Each physician in this group looking at 24 STEMI cases out of that pool of 5,000. This study is actually pretty interesting because it actually includes physicians at WashU. And so this included nurses, medical students, cardiology fellows in training, PCPs. And again, there were 1,206 participants in this study. And they had them look at ECGs, and in particular for STEMI, they found that cardiology fellows were the most accurate, at 77% accuracy. Residents were 70% accuracy, and accuracy across all physicians was about 70% for STEMI. So not a super reassuring number yet, right? 65 to 70% accurate for STEMI, and I'd like to be really reassured if I see an EKG that it's STEMI. So the next question becomes, how accurate are the current computer interpretations, right? Every time you get an ECG, there's a computer read at the top. How accurate is that, and can you trust it? And so in order to understand that, we have to understand what our current algorithm is. So we use an algorithm called the Marquette 12SL algorithm. Importantly, this is a rule-based algorithm, and I'll discuss what that means. And it's created by GE, and GE owns the vast majority of these ECG algorithms that are used in hospitals currently. And so what rule-based means is that it's a bunch of if-then statements. So if there's a P wave and it's upright in lead X, then diagnoses Y are possible. Or if the ST segments are elevated greater than X millimeters, then it's a STEMI, right? And this is important framework because when we talk about AI, they actually use a different algorithm. And so let's talk about some of the studies that have been done on the Marquette system in particular. So this study, this is out of France in 2020. It was a retrospective analysis of STEMI. 379 patients were included. And it's found that the sensitivity for the algorithm was about 90.5%, with a specificity of 99%. And I got curious, and I wanted to know what other algorithms on the market looked like. This study is actually of the Phillips algorithm, so a different algorithm entirely, but it found that confirmed STEMI was 93.7% accurate for that algorithm, but any ACS event, it kind of fell off, 86% accurate, and the sensitivity in general was lower than it was for the Marquette system. But again, if I'm looking at an EKG and I'm running it through something, I would love if I could be like 100% certain that this is STEMI, right? In an ideal world. And so what is our pathway to improvement in this space? How can we do this? So enter the Queen of Hearts. So the Queen of Hearts is a phone application. You can download it right now from the App Store. And it's created by a company called Myocardial, or Powerful Medical Cardio. It's an AI-powered algorithm. And it was created by a group of physicians, some from the United States and others from Europe. And they asked essentially two questions in creating this algorithm. One question is, are MIs being missed? Are there people that we are not sending to the cath lab fast enough? And two, on the flip side of that, can we reduce activations? Are we sending people to the cath lab and they go and they have no CAD actually? So how do they sort this out? So in order to kind of better create an algorithm that identified this, they had to go with some new nomenclature. So let's review our current nomenclature. We are very familiar with STEMI and NSTEMI, right? And STEMI and NSTEMI at their core are ECG diagnoses. STEMI being elevations of the ST segments and contiguous leads, except for V2, V3, which changes for age and sex, and STEMI being depressions and contiguous leads, or T-wave inversions and contiguous leads. These are the common things we think about. And their argument was that there are patients that are not fitting the STEMI criteria on ECG, but when we take them to cath lab, they actually have acute occlusive events, and so they're not going fast enough. So how do we find those patients? So they created nomenclature called OMI and non-OMI. OMI being an occlusive myocardial infarction, non-OMI being a non-occlusive. And these are clinical definitions, right? This is a definition of when you go to cath lab or when you look at the patient, right, you're making this definition based on what you see, what is actively happening to the vessel. And then they ask, can we work backwards? Can we find ECG patterns that fit these definitions, right? So not just STEMI anymore. What other things out there fit this occlusive definition? And one of the physicians involved in these studies, Dr. Khan, had some retrospective data that showed that as many as 25 to 30% of NSTEMI patients were found to have these total occlusions when they went to cath lab, which seems like a really high number, right? Okay, so I introduced the algorithm. I told you about the nomenclature. How did they make it? So what they did was they took 900,000 ECGs across a 16-year period on 117,000 patients. And they utilized 6 deep neural networks to build this algorithm. And they fed it essentially 20 diagnostic patterns within 6 groups. So those are things like ACS, conduction abnormalities, ectopy, chamber enlargement, rhythm, and axis. So they fed this into the network, and that's how they created it. And we'll get to how they validated it in a second, but let's go back to that EKG I showed you initially first. So this is what I showed you to begin this talk. So let's put it through the Queen of Hearts. So if you have the app, what you do is you open up your phone, and it has a camera on it, camera function on it, so you take a picture of the ECG with your phone. And within about 10 to 20 seconds, it generates this nice big old digitized version, and then it asks you a question. It asks a question that says, is this patient having ACS symptoms? Meaning, are they having like chest pain? So I clicked yes, because I told you this patient had chest pain, and it creates this outcome. It says STEMI, STEMI equivalent in big red letters. Very hard to miss, right? And additionally, it gives you this heat map. And what this heat map is showing is it's telling you where the app thought that there was a problem. So the app is saying, hey, it leads V3, V4. That is what I am reading as abnormal. And to further prove the point, maybe you don't agree yet. Maybe you're like, this person didn't need to go to cath lab. So let's look at their left heart cath. So this is a cranial projection. This is the circ. And this is the LAD. And it should be coming all the way down the screen in front of you like this. And it's truncated right here, because this person has an acute occlusive myocardial infarction, right? And to further prove the point, this is what the Marquette algorithm would have told you. So it says a sinus rhythm with a marked arrhythmia and an ST and T-wave abnormality, but nothing up there that says acute MI like it usually does in the big letters, right? So this would have been missed on this algorithm. So let's talk about how they validated this application. So this is a study put on by Myocardial. It was published in the beginning of 2024. And what they did is after they built the algorithm, they took 4,200 EKGs, and they fed them into the algorithm and then also into the Marquette algorithm. And so when they fed them into both, the way they figured out which EKGs to put into this test subset is they had 2 cardiologists read them, and they both had to agree on the diagnosis. So across those 20 categories I talked about earlier, both cardiologists had to agree on each EKG. If they disagreed, it wasn't included in the test subset. And so then they tested the performance of Queen of Hearts against Marquette. And what they found is that Queen of Hearts in 13 of those 20 categories was more accurate, and in 7 remaining categories it was non-inferior. And additionally, they found that it reduced false negatives to nearly 0, and it also increased true positives by 20%, and that was for STEMI. Okay, so I said, though, that this is done by Myocardial, right? This is done by the people that built the app. So this technology is super new. It got FDA approval 3 months ago. So there's not a lot of studies on it. So we did one. So this is our validation study using our patients. So we did a retrospective analysis with information compiled from MI pager activations from January 2022 to August 2024. And an MI pager activation is basically when you have concern for an acute coronary event. Maybe you look at the EKG, you think this person's having a STEMI or NSTEMI, so you activate the pager to have a cardiology fellow then triage to come look at the patient, look at the EKG, and talk to their attending to see if cath lab should be activated. Or maybe you had an EKG, you weren't super concerned, but then the trope came back super elevated, right? So this is how the pager activation occurs, but it always results in the fellow and the attending talking about the EKG. And activation, as you can see here with this pie chart, most typically by EMS, over half the time, and the other major proportion being the ED, with a little bit coming from the ACT team for inpatients. And in total, in that time period, 471 patients had an activation of the pager and fed almost 900 ECGs into the application itself. Our methods were, we put all EKGs through the software. However, for our analysis, we used the EKG that activated the MI pager. So let's say you came into the emergency department at noon, and you got an EKG and it didn't activate the pager. And then you got another one at 12:30 and that activated the pager. We would run both through the app. We have data on both. But the one who activated the pager is used in our analysis. Now, I told you earlier that they used nomenclature for this that is different from STEMI and NSTEMI. So we had to kind of rectify how we were going to diagnose these OMIs, right? How are we going to make sure that this is an occlusive event? And like I said, this is very new technology, but there are limited studies out there, and they've kind of trended to use this definition, and we use similarly. So this is coronary angiogram evidence of an acute occlusion was defined as TIMI 0 to 2 flow. TIMI flow being a parameter by which we can look at how much flow is going through the coronary arteries, with 3 being the maximum. And then for people who did not go to cath, right, because not everybody goes to cath, for those who did not, it was defined as a significant cardiac outcome, which would be like a troponin greater than 5,000. And in particular, this would be for patients who did not have like otherwise reason for troponin rise. And these are our endpoints. We're interested, of course, in diagnostic performance. So sensitivity, specificity, predictive values, and accuracy. So here's our demographic slide. As you can see, about 2/3 of the patients were male, predominantly in the 60 to 69 age group, though some patients under 40. And as far as race and ethnicity, over half of our patients were Black non-Hispanic, but white non-Hispanic and Black non-Hispanic patients made up about 95% of this cohort. So here's a breakdown of how the patients were read by the application. So like I said, 471 total patients, 56 excluded. So why do we exclude them? If a patient expired on their way to the ED or in the ED, they were not included. So let's say they were getting CPR in the field and they expired in the ED. They weren't included because we didn't have the ability to determine if that OMI was real or not. OSH transfers were excluded because we did not know. Basically, it's not the same kind of activation parameter as we use, right? We're talking about MI pager activations. They don't use that. Therefore, we didn't include them. And then lastly would be incomplete data. If you don't have the activating EKG, I can't include you in the analysis. And so 415 of those patients were included, and of which the app identified 234 as having an occlusive myocardial infarction, and 181 as not. And then splitting them down by who went to cath, 192 of the people in the app group that were identified as having an OMI went to cath, 42 did not, and 181 of these non-OMIs 25 went to cath, and 156 did not. So let's look at the differences between these two groups. So again, these groups should be significantly different from each other, right? We're saying that one's having an occlusive event and one is not. So when we break it down by cath, 192 versus 25 is statistically significant. When we break it down by troponin, the peak in the OMI group is 2.5 million almost, with a median of 18,000 versus this median being 37, which is statistically significant, right? When it goes to STEMI, this is really important. There are no STEMIs that were missed. Every single STEMI was caught appropriately by this app and identified as OMI. And then notably, in between these groups, mortality and length of stay did not differ, right? Both being about somewhere around near 3.5 days. And this also was not statistically significant difference in mortality. So let's look at our primary endpoints. So at the top, I have people that were clinically identified as having either an occlusive event or not. And on the column, of course, I have what the Queen of Hearts said. So 188 people were true positives, right? Identified by the app and identified clinically. We have 46 false positives, identified by the app, but not appropriate clinically. 11 false negatives. App said not an OMI, but clinically we thought otherwise. And 170 were true negatives. So what does that amount to for you? It amounts to a sensitivity of almost 95%, specificity of 78%, positive predictive value of 80%, and a negative predictive value of about 94%, with an accuracy of 86%. And just to put this very clearly into clinical terms, right? This is saying that there are 170 activations of the MI pager that the Queen of Hearts and you would have agreed did not need to happen, right? That's a very large amount of these pager activations that are caught appropriately by this application. And the trade-off of that is that there are false positives, right? This is a very sensitive application. So the false positive group is not small, but the trade-off is huge. So let's talk a little bit more about these false positive and false negative groups, just to really spell out how we identified them clinically. So like I said, 46 false positives, of which 13 had 2 negative troponins, very easy rule out, and 8 went to cath and had no CAD, also a very simple rule out, right? Of the others, over half the group actually had a very low max troponin, less than 50. And 46, out of the 46, 44 met our definition. Remember, our definitions of OMI were angiographically TIMI 0 to 2 flow, and then troponin less than 5,000. And so 44 out of 46 met that definition. 1 had endocarditis. This would meet our definition of kind of other reasons for cardiac inflammation. Theirs was greater than 5,000. And the other one had a cath 1 week prior. This in the ACS algorithm is considered like a type 4 post-procedural MI, which is just from instrumentation in the vessels. And then false negatives. 10 went to cath and met our definition of OMI, TIMI 0 to 2 flow. And 1 did not, but notably it was because they refused cath, and they did have a troponin greater than 5,000. So my key takeaways are this. I did not give you any kind of algorithm that could 100% accurately identify STEMI every time, but Queen of Hearts has. And to prove a further point, a recent study actually just came out like 6 days ago, and they also found that Queen of Hearts grabbed 100% of STEMI cases correctly. Queen of Hearts has an accuracy of 86% for ACS, which is quite high. And it could decrease MI pager activations. This is balanced with, again, a really sensitive application that could have formidable increase in false positives, right? But overall, the true negative population was quite high. As far as our discussion, I think this data is really applicable to people with super high suspicion for ACS, right? These are people with chest pain who are coming in for chest pain, right? This isn't applicable to the masses. This is a high suspicion, high probability group. Limitations, I myself fed like 700 ECGs into this app, so I'm very familiar with what it's good at and what it's not so good at. I think that one thing that would make the app really good is if it could compare to prior EKGs. Because if it can compare to prior, I think that would get rid of a lot of issues where some STEMI equivalents, like a left bundle branch block, right? That can be a STEMI equivalent. But if it's been there for a couple of years, you're not as concerned, right? But the app doesn't know that, and it's just doing what it's taught, which is that that's a STEMI equivalent, so it's going to call it as an OMI. But other things that the app is taught to do, it's taught to be hypervigilant to a lot of these STEMI equivalents in general. So hyperkalemia, it kind of struggled with. It was calling it as like hyperacute T waves for a STEMI equivalent, early repol, and then Scarbosa criteria in the setting of left bundle branch blocks. It also struggled with reading appropriately, meaning it would overcall on these. And lastly, but certainly not least, I think this app should be used as a tool in diagnosis, but it's not your sole diagnostic device, right? If having this app in your back pocket is what pushes you to call cardiology and activate an MI pager on a patient where you're not really sure what's going on with the EKG, but it says STEMI equivalent, then I think it's doing its job, and I think that's super helpful clinically. I want to acknowledge Dr. Bach and Dr. May for being incredibly knowledgeable on this subject, incredibly knowledgeable about cath, AI, and everything in between, and being very helpful to me with this preparation. Fred Brown and Sam Harris did a lot of the legwork to get us access to this app. We had access to it about a year before FDA approval for research purposes only. They did a lot of the legwork to get that, and they Sam also pulled a lot of data, which is very helpful. Tony Dow, because he helped me go through my slides, which I'm super appreciative of. Mentors in Medicine for funding this project, Myocardial, and WashU IM Residency for giving me the opportunity to talk today. These are my references, and I will take any questions you have. Yeah, Dr. Kachi. Thank you. That's a great question. I want to answer that question by saying, yeah. So Dr. Kachi asked if access to this app, is this app free, and why should we be using this essentially? So I want to give a caveat here. This app is not free, but I don't know if a resident is who you should ask about financial usage of apps. But the app is it's $25 a month for if you do like the annual subscription for individual access. You can get institutional access, which is different. I don't pay for the app because I have it through research purposes, which is another caveat. But if you do the free version, you get like 5 ECGs a month, but you don't get access to like the heat map portion of things. But I do think for the diagnosis of STEMI, I think like in particular in the ED, I think this could be super helpful. There's only actually one prospective analysis that's been done so far in the United States. I believe there's 1 or 2 out of Europe because it's so new. And so I think that's really where we need to go next, because that would help us in making conjectures about like cath lab activation and decreasing activations and such as well. But yeah, very limited data on that front. But overall, I do think it's actually quite helpful. Yeah.
Again, fascinated by the data. I think one thing you can do from this is actually turn it around and say, take the heat map, what are the lessons we can learn to be better as humans without the AI? We do that in the imaging space all the time. We use third-party meta-analyses for our CT data sets. But we're trying to turn that around and say, now that we've been trained by the AI, who needs to be the AI? So those heat maps, I think, are fascinating.
Dr. Kachi brought up that the heat maps are really fascinating, and can we learn something from them? And I want to bring up that study I mentioned at the very end that was published like 5 days ago, they do a really nice job of laying out STEMI equivalents and what humans and the Marquette algorithm really struggles with. And I think a lot of those would probably be caught on that heat map, things like Wellens, DeWinters, hyperacute T waves, et cetera, that are STEMI equivalents that we just don't do a great job of catching. But I think that's a great point. I'm gonna walk around. Thank you.
All right, up next we have Dr. Marcela Santana, who earned her medical degree from the Federal University of Uberlândia School of Medicine in Brazil. Before starting residency, she conducted research in leprosy, deepening her interest in infectious disease. She's now a PGY3 in internal medicine here at WashU and is a member of the Global Health Pathway, reflecting her commitment to international health and cross-cultural care. Dr. Santana is an aspiring infectious disease and critical care physician. Please welcome her to the podium.
Hey everybody, can you hear me okay? Okay. So I'm Marcela, I'm a PGY3 here, and today I'm going to talk about decolonizing global health. And my presentation was inspired by my experience with the Global Health Pathway and mentored by Dr. Matar, who is the director of the Global Health Pathway. So for today, my main learning objectives is to first reflect on the historical trends which affected the health globally, then define the decolonizing global health movement, and discuss solutions for equal partnership in global health. So to give you a general context, global health is an area of study and research and practice that try to focus on improving the health and also try to achieve global equity in health for all people. And throughout the history, one of the bases of the global health collaboration and how it was started was the partnership between high-income countries and low- and middle-income countries. So thinking about those partnerships and what those relationships mean, we have a lot of concerns about the imbalance in the current system. And some authors believe that that happens because of the legacy that we have from former colonial relationship between those countries and the power inequities. So to talk about some of those concerns and some of those possible imbalances, I'm trying to break through to some of the topics that we have in global health. So for example, global health leadership and funding. So there's this organization, the Global Health 50/50, that they do several analyses throughout the years about the differences in funding and leadership in global health. And here you can see the headquarters of the 198 global organizations that we have that are active in global health and health policy across the globe. And if you see, in North America and Europe, we have the majority of those organizations. And only, for example, 1.5% in Latin America and 7% in Africa. And then when you look at global health leadership across the globe, we also have this power imbalance when you see, for example, the global population that are 82% in low and middle income countries, when you have 82% of the leaders for global health being high income countries. And two countries, the UK and the US, they have 50% of those leaders. And also when you think about global health education, for example, only 8% of the degrees were obtained in low and middle income countries. And if you compare, for example, Harvard School had 8% of degrees from high income countries. So when you start thinking about funding as well, we have the Official Development Assistance, ODA, which is one of the majority of the money that comes from global health. And unfortunately, for the next few years and in the past few years, we had a significant decline in funding. So we projected that 40 to 60% of decline on ODA in global health in the next 5 years. And this is going to be critical for some healthcare systems in low and middle income countries that are going to confront an urgent funding crisis. And if you see here, you see that the US is one of the countries that had a lot of ODA funding, and it's projected a significant decline on that, and same for Germany and UK. And the problem with that is exposing some of the countries that rely a lot on that ODA. And for example, by the gap that the US will leave when that money decreases, we have 26 countries that are going to be highly exposed and highly fiscally constrained when they don't have that money. And that also leaves us with an issue that when the countries have this risk of being dependent on all those external donors and agencies to provide their assistance, which can also fragment and undermine their local healthcare system to develop. And we have some critical areas, for example, HIV, TB, malaria, and maternal and reproductive health that are going to be severely affected when that money decreases. Then you start thinking about global health education, and like I mentioned before, because of this power asymmetry, we have several structural inequalities that results in the dominance of high-income countries' universities in global health teaching and research. And you also have the high financial cost that students from low and middle income countries face when they try to go for more teaching in high income countries, which is going to contribute to the brain drain from low and middle income countries to high income countries. And again, you can see a very similar map from the first one, where you have master's degree for global health or international health that are mainly located in North America or Europe. And you can also see that the tuition is quite costly, and it's especially more for international students. And here, for example, you only had one master's degree in Africa and 2 in Asia. And the same happens for conference in global health. So there is this paper on conference equity in global health, where you see where the global health conferences are located, and they also analyze the participants for those conferences. And you see that they are mainly located, again, in high-income countries. And a lot of the participants on those conferences, they are also from high-income countries. And there's several issues with that, because you know that there is several financial barriers, visa restrictions, political problems when participants from low and middle-income countries try to go to those conferences. And then when we look into research in global health, we again see those power differences. So there's this review of our articles on research in Africa that showed that only around 50% of Africans were first author, and some papers even fail to include any authors from Africa. And then when you look into Lancet Global Health, they did a review of 239 articles, where 64% were focused on low and middle income countries. However, only 35% of the authors were affiliated or came from low and middle income countries. So what that leads to is some of those structural inequalities produce something that we call the parachute research, where a lot of researchers, they go to low and middle income countries for a short period of time, collect research data, and then they leave, which can lead to unfair research partnerships. You can have some maldistribution of benefits, and you can also lead to problems. For example, the research system in that place or the culture can be severely affected by that. And then we also know that there is problems, for example, with practice changing clinical trials that are going to alter guidelines, and those trials are usually done in high-income countries. And even when low and middle-income countries are included on those trials, some of the participants and people that participate in that study will not have access to the drugs that were developed with that research due to cost. So in light of all that, some authors created something that we call the Decolonizing global health movement. It was a movement that gained momentum around 2018. This movement acknowledged the power imbalance and inequities and bias that we have in global health collaborations, and tried to work to create and maintain a mutually beneficial global partnership that is also rooted in cultural humility and equity. And why we were trying to raise this movement is because we know that global health has been more dominated by actors and institutions in high-income countries, which generates this imbalance in knowledge production. And then this status quo in global health doesn't offer fair opportunities for low and middle-income countries. And some authors believe that to try to identify the root of this cause, you have to go back to the colonial area. And then you might think that that's really not easy, and it requires a lot of change. So some authors, they advocate that we have to try to approach that in a systematic approach to try to change the level of practice, the level of institution, and the level of policy. And then you think, what can we do as students, as an institution? So there are some movements that have been trying to help with the decolonizing global health. So for example, we can decolonize by applying the fair trade principles when you do an educational program. So the fair trade learning is a movement by the Global SL that try to get a partnership exchange that is going to prioritize cooperation and cross-cultural participation to make sure that we have this balance between the students and volunteers and the host communities. So the goal is to have economic equity, equal partnership, mutual learning, cooperation to lead to a positive social change. So some of the pillars for the fair trade learning, the first one is that the projects have to be community driven. So they noticed that a lot of projects in global health, they were not raising from the community, and they were not trying to have principles and things that the community thought was applicable and was going to lead to change. So the main thing here is to make sure that the community is involved in the selection, the implementation, the recruitment, and all the phases of that project. Then the next thing is to make sure that caring should be credible, and that's mainly a concern about patient safety. And for example, they have some principles that you have to be professional qualified. If you can do that in your country, then you can do in another country. And make sure that, for example, they mention children are too important, and by that they mean that if you are going to work with children, you have to make sure that they have the continuity of care. And the other pillar is to make sure that you have a partnership that are capital conscious, and that it was inspired by a research that showed that some of the global health experience in South Asia noticed that when they were investing money, they're investing money in students, only 5% of that investment was actually staying in the community and leading to a significant change. And after they start applying their fair trade learning and the principles, it changed to 70%. And what else can we do? So we can decolonize by emphasizing patient safety, which is kind of in the second pillar. The University of Minnesota has created a global ambassadors for patient safety, where it's an open access and online platform where students are going to reflect and think about ethical issues that they might encounter abroad when they go for our global health experiences. And that is mainly to make sure that they understand that things could be culturally challenging, the language can be different, and all the ethical issues that you might have raised for that. And then you also have decolonizing by equalizing access and opportunities to educational experiences. So we know that there's this growing recognition that we need some exchanges to be reciprocal between countries and communities. And here I have an example of our own WashU Global Health, where we have been trying to co-create and co-develop programs, so investing in the international partners. There is always a need assessment with the partners to identify where the need for investment is and where they want the money to be invested. And then we already have bilateral exchanges for medical students. We still don't have for residents and fellows, but we are hoping that in the future that might happen. And then when you think about research, some of the things that can be done is that to make sure that you have co-development of research priorities, to make sure that you're recognizing the local expertise in that country. And often some of those research projects, they are disease-oriented, and by that I mean they are trying to learn more about pathophysiology and treatment, which sometimes doesn't lead to a patient-oriented approach. So all the global health projects must try to shift from the disease-oriented research to a patient-oriented and health system-oriented approach. So the main takeaway from this is that it's not an easy change, and some authors also say that we need an economical development to take place in global health. So the global health is not only a temporary blood transfusion in a body that already has a chronic hemorrhage, and also reviewing the global health through the lenses of colonialism is an opportunity to think about the whole power and inequities that we have in global health practice. My main take-home message is that the history of colonization impacted the healthcare disparities in the field of global health, so we should try to dismantle and reimagine global health practice and research to be mutually beneficial. And for that, we need to try to become more self-aware of our position, our power, capital, cultures, and perspective and actions, and try to practice this continuous self-reflection and how this is going to impact your global health partnership and work. And try to approach the global partnership with cultural humility, respect, curiosity, patience, and flexibility. And I'd like to thank the Global Health Pathway and Dr. Matar for my mentorship for this presentation, Dr. Cheng and the Chief Residents for inviting me for this talk, and the Department of Internal Medicine. Any questions?
Good to see everybody for the first Grand Rounds. Do we have some questions? I have a question, Ingo. So for global health initiatives that we're doing, with our students, our residents, are there things that you think we need to adjust and address to be even more effective, as advocates and as champions for safety and quality in health systems?
Yes, so I think our Global Health Pathway is doing a great job, especially trying to make sure that the investment is staying in the community. And the next step, I would say, I was talking with Dr. Matara about that, is that we still don't have that bilateral exchange in residents and fellows, which is already happening with the students. So I think that would be really nice to know that we are sending residents there, but we are also receiving some of their residents and having that mutual benefit. So I think that would be a good next step. Thank you so much.
All right. Thank you, everyone, for coming to our first Grand Rounds. Hope to see you next week, okay?